Good morning, ladies and gentlemen, and welcome back to our third Cadaver session with live demonstrations here in the RevoSpine Wet Lab. Today, Dr. Yarokoglu is presenting an interlaminar approach for far caudal migrated disc herniations. He is going to perform this with our vertebrous lumbar system that you can see right here. Dr. Yarokoglu.
Yeah. Okay, welcome everyone from my side. I'm going to demonstrate today how we can reach the far caudal side of the level. As you know, we prefer to do it with the interlaminar approach. The reason for that I'm going to tell during the demonstration. We start with straight AP. I'm doing that on the right side of the cadaver, which means that that side is the cranial, that side is the caudal. And we set the C-arm at the straight position as usual, for the interlaminar approach. Then I mark the interlaminar window, and there is a small trick here. Always for the regular disc herniations, we prefer to mark the middle of the interlaminar window, but for the far caudal migrated disc herniations, I would prefer to mark a little bit the cranial side of the interlaminar window to look more caudally under the caudal lamina. Okay, I just marked the skin, and then the next step is the skin incision. Then usually the half centimeter skin incision is enough, and the important thing is to cut the fascia also. Directly with the dilator, if you didn't cut the fascia, it's not easy, and I highly recommend you to do it in advance. Then I introduce the dilator straight, and I feel the bone at the lateral side. Which bone? I don't care about it. The lamina, descending facet, caudal lamina, ascending facet. The important thing is not to pass through the phloem ligament. Then now I see the tip on the bone in the C-arm, but I would like to check how deep I am. Yeah, I see the tip there, but probably very rare complication that I could pass through the phloem and go into the spinal canal. Then if this happens, I would like to check it, and only I would like to be with the dilator there. Okay, let's check the level. Maybe we can go more.
Ladies and gentlemen, whenever you have questions to what you're seeing or questions to how you can progress in your education, please feel free to type them into our YouTube chat.
Okay. Then I see that my dilator is outside of the spinal canal, then I can continue the procedure. Next step after the dilation is introducing the sleeve. We use the 30-degree bevel sleeve, and the handle we attach like that. Every time by this way, I know the opening of the I know the opening of the sleeve according to the handle position, and I introduce it towards to the phloem ligament, means that to the medial aspect. Okay, the approach is done. The next step is the endoscope. First of all, we have to clean all the soft tissues around the phloem ligament and also the bony structures. What you see here is the soft tissues and the fascia from the muscles. Okay. Then the rongeur. What I do here, I catch the soft tissues with the rongeur, grab it, and leave it on the way, then the irrigation takes them out. Okay, for your orientation right now, I will give in a second. The 3 o'clock is the cranial side here, and the 9 o'clock is the caudal side in this position, and also the 12 o'clock is the medial side. Then I can feel the bone, the facet joint here. Then you see the muscles again. Okay, Bonjour, please. At the same time also, I press the working sleeve down. Now we see the ligament here. Then I would like to clean more caudally like this. Yeah. Okay, first of all, basically, especially for the far caudal migrated disc herniations, there's a possibility that mostly the herniations are located in the axilla of the level, and we have two options. If it is really fresh, that you can try to catch them from the shoulder, but the best way is to explore the axilla and remove it from the axilla first. Okay, let's check once again. Then what you can do, you can open the phloem ligament, or before that, you can drill the caudal lamina just a little bit to reach more. To do that, I would like to find the ascending and the descending facet junction first. And it's here that I can feel that. I'm on the bone, okay? Then I will do the opening with the phloem ligament. Then I just go with the scissor, and every time I would like to see what I'm doing. If I use it straight like that, I don't see what I'm doing, but I keep the direction of the instruments and I rotate my endoscope a little bit to see the tip of the instruments, what I am doing. Yeah, you see the phloem ligament, and every time with the sleeve, I stretch the phloem ligament and I just open it. Once you open it, the irrigation creates a space between the phloem and the structures, and then I just put the backside in and I advance my incision to the lateral side. Then I see something, and I would like to clean all these tissues in front of me. To see the neural structures first. With the 4 megahertz radio frequency device, you can easily work really close to the structures here. Okay, I start to see something, but I just want to know what they are and explore more. Okay, now what we see, it looks like neural structures, and these are the vessels located in the recess. I just coagulate them in advance, not to have a problem later. Okay, I see the neural structures here, and then when I go to the medial side, I see another one. It looks like an axilla here. That I can see easily at the level of L5S1. And then what I can do, can place my cannula here and rotate 180 degrees. By this way, I protect the nerve root behind the cannula, and then to reach the caudal side or to explore the caudal side, I rotate my cannula to the caudal side and also my endoscope to the caudal side. We are working with a 25-degree endoscope, and then by this way you can easily reach the caudal side of the level. I will show you how we can reach there without any, how far we can reach without any bony resection, just a 2 or 3 millimeter incision on the phloem, and then we are at the caudal side of the level. Can I have the rongeur? Okay, then if there is a fragment located somewhere here, then we can easily reach there. Then I would like to show you where we are. Almost we are at the caudal side, but even if you want to do more, or if the pathology is located in the axilla, then what we do, we have two options. You can use your rongeur without sleeve protection to the nerve root, that you can go with the rongeur like that and try to catch the fragment from the shoulder, but mostly it's not possible. Then we go to the axilla and explore the axilla more, and then we can remove the fragments from the axilla here. As you see, this is the nerve root. This is the nerve root, the shoulder of the nerve root, and the caudal, the thecal dura, and then also this is the axilla of the S1 nerve root. We are at the level L5 S1. You see the shoulder of S1 nerve root, the axilla of X1 nerve root, and we can check the caudal side easily without any bony resection. Okay, now we have another option, of course, with the transformal approach. Even if you want to reach here, you have to do facet resection, and then, in my opinion, it's not very practical and easy to reach the axilla, and more than the axilla, the caudal side of the level. Okay, again, if it is located more caudally, then what we do, we can increase our resection to the caudal side. We can resect from the caudal lamina like this. You see the upper edge of the caudal lamina here. Then we can, but what we prefer to do that before opening the phloem. Can I have this one? Then I would prefer to resect the posterior part of the lamina first, like that, with the diamond 4 millimeter burr. We have to be very careful because, as you know, the insertion of the phloem at the caudal lamina is really located in the cranial side of the lamina. Then with the drill, you can easily open it. Yeah. But I just want to make it thin, and the rest I can cut it with the regular kerosene. I'm on the caudal lamina again. The right side of the picture is the cranial side. The left side, at 9 o'clock, is the caudal. 12 o'clock is the medial side, like in the microscopic view. Okay, can I have the kerosene also? And also now with the kerosene, I can go to the caudal side like that and easily reach more caudally. And also we prefer to do that for the recess decompression. Just clean, could you clean this up? Okay, more from the caudal lamina also. Now I just cut the caudal lamina, the upper part of the caudal lamina like that. And then I had the rongeur. Again, if we want to do bone resection like that to reach more caudally, we prefer to do it before opening the phloem. And can I have the kerosene again? The reason for that is the phloem is really good barrier and the protection for your procedure. Okay, already I resected the rest of the phloem here. The rongeur, please. Kerosene rongeur. And if you have any questions, please use the chat function of YouTube that I will try to answer during the live. Okay, let's see what we did. Again, you see the root here. The axilla. You can explore the axilla like that. You can do this only with the 4 megahertz radioablator. It's too much with the conventional bipolars. Then you can reach more. And the importance of this, also we see what we are doing. Yeah. Always there's a discussion, can we reach that part with the transforaminal approach? My opinion, it's not very easy, yeah, but too many surgeons prefer to do that. To reach here with the transforaminal approach, at least you have to resect the facet joint, maybe some part of the pedicle. Rongeur, please. Yeah. And also, again, probably you will see some part of the here and maybe the cranial part edge of the fragment that you can catch it, but you cannot be sure that you left anything in the caudal side or not. But with the interlaminar approach, as you see, you can see what you are catching, and I will show you how far caudal that you can reach here. As you see, almost we reach really far caudally. Also, if the pathology is located in the axilla, then we can go with the rongeur and catch the fragment from the axilla and remove it. Then later you can place your working sleeve and rotate the working sleeve 180 degrees and retract the root to the medial side. Then by this way you can reach the defect on the annulus. Yeah, I think this is the technique to reach to the far caudal migrated disc herniations. And I would like to show you one more thing. Here you see the pedicle, and this space is here. Yeah, with the transforaminal approach, maybe you will reach here, but not more than here. That you can explore that side, also the axilla, like that. The reason to do it for us to do interlaminar approach to reach the far caudal migrated disc herniations with the interlaminar approach is that. Of course, I presented you the first without bone drilling that we can reach. In this case, you wouldn't have this defect on the phloem. You have only one incision, not more than the 2 or 3 millimeter, and by stretching the phloem, we can easily reach there. And also, if I would prefer the bone resection first, then I could do bone resection first, and then open the phloem from here to here again to have a less defect. I think this is the technique to reach the caudal site, far caudal migrated disc herniations.
Thank you very much, Dr. Yarkoglu. We have some questions from the audience. The first question is, what is the name of the system that we have here? It's the RevoSpine Vertebris lumbar system. And the second question is if we can introduce several instruments into the endoscope. Most of our instruments, they take most of the volume inside the endoscope, which means that you can only use one tool at a time. Then the third question that we have, Dr. Yarkoglu, maybe you can answer that one. Does it matter if the patient is a very heavy patient or a very thin patient? What is the difference?
This is the big advantage of full endoscopic surgery. It doesn't matter for us. We just mark the interlaminar window and we introduce the dilator and the sleeve area on the bone and on the phloem ligament. This is the big advantage of full endoscopic approach, that you don't care about how the patient size or the fatty tissues there.
So if I get you right, it means also that the surgery time for a thin patient and a thick patient are exactly the same, yeah? Because the
no difference, yeah. Only the positioning of the patient may be a little bit difficult for the fat patients, but it's not a problem. What we do, the same steps. We just mark the interlaminar window under the AP control, and we do incision, and then directly we go with the dilator, even with the 5 centimeter fat tissue or 10 centimeter fat tissue, it doesn't matter.
I hope that we could answer the questions that were given. Do we have any more questions?
Do you prefer to use the bone punch instead of the kerosene for expanding the opening of the phloem?
So again, I didn't get the question.
Do you prefer to use the bone punch instead of the kerosene?
So the question is, do you prefer the bone punch instead of the kerosene punch?
Bone punch means the tube punch, yeah. Basically, I like the tube punch, but because I feel more stronger that you can cut the bone, but both of them is available. Yeah, it's the same. The tube punch, always you get the bone from the lower part to the up, and with the regular kerosene you cut it from up to down. But I'm used to work with the bone punch, tube punch kerosenes.
Okay, we have another question about the hemostatic technique.
So we have another question about the hemostatic technique.
For bleedings, yeah. For the bleedings with the full endoscopic technique, from the epidural area, it's very easy. We just use the coagulation. And always the bleeding can be a problem at the beginning from the bone. We have two possibility to stop these kind of bleedings. First of all, again, you can use your bipolar to stop the bone drilling. But at that time, exactly you have to place the tip of the bipolar on the bleeding part on the bone. Usually they are very small. And the second possibility is the diamond burr, that you can drill the bleeding part and you can stop it. This is the options.
We have another question. One question was coming in regarding what you said earlier, that you can work close to the neural structures with the electrode. I think that there was some question left.
Sure, yeah. We are working with a 4 megahertz with a high frequency. The reason for that is the heat really doesn't go so deep with the tissue if you work with the high frequency. Then it allows you to work very, very close to the structures. Usually the bleedings are nothing for the patient, but it's a problem for your visualization. That's why we prefer to stop all kind of small bleedings. Maybe I can show you sometimes, especially if you work with the axilla. As you know, there are a lot of vessels located in the axilla, and you have to coagulate them like that. Really, you can use your radioablator bipolar and like this to stop all the bleedings from here. Sometimes you see, especially on the dura, it's bleeding, and then with one shot very close just on the dura, that you can stop all the bleedings. You can do this only with the 4 megahertz radioablator.
Thank you. I think the question was answered. One more question. Can we use in the interlaminar technique indigo carmine to stain the disc?
For the if the topic is to the far caudal migrated, especially we explore everything, we see what we have in front of us, then we don't need an indica carmine for this. Yeah.
We have another question here.
There's one more question coming up.
You get through the phloem very quickly. This is often the most challenging part for new users.
So the question is that
you
go very quickly through the phloem, and if you this is a very difficult part for new users. So what's your opinion?
You're right. Also, the most difficult part, for my opinion, for the beginners, for the interlaminar approach, is to open the phloem ligament. There are some tricks here. Of course, we focus more on the trainings with these and with the hands-on trainings. The tricks are like that. First of all, you have to have a clear picture from the phloem. Yeah, just dissect all the soft tissues around the picture, and then just to see the clear picture from the phloem ligament. Then the second important thing is the positioning of the patient at the beginning. We have to we have to correct the lordosis of the patient first. The reason for that, you can open the interlaminar window more, and the second reason that you can stretch the phloem. If you don't stretch the phloem, if the phloem is relaxed, then it's not easy to open. Okay, the other trick that what we do, usually we place our finger here, and then maybe Johan, you can change to the yeah. Then we press like that. Yeah, I can feel that. I press and I stretch the phloem ligament. Then once you stretch the phloem ligament, it's really easy to cut it. And the best, can I have the share?
Scissor?
Yeah, okay. And the best maneuver to cut the phloem is that. Mostly I see during the trainings the participants doing like that, but it's not good. I open it, I press the working sleeve to the phloem to stretch it, and I open the mount of the scissor, and I just press it on the phloem, and I catch it and cut it. Always, I can understand that the surgeons feels that, it's dangerous, that I can catch the dura or not, but the design of this scissor is really important on this step. As you see, the cutting part is just behind the back part, and then by this way, with the tip of the scissor, first you push, and the cutting part is coming later. Then you cut it, and once you open it, the irrigation creates a space there. Then we use the scissor like that again. This blind part is in front, and then we put it here, and we pull the phloem a little bit, and then cut the phloem on the tip, on the back side of the scissor. This design is really important. It's not exactly the same design with the scissors.
And I assume that for the regular approach, we work on the ipsilateral side of the herniation, so we're not going to the contralateral side in a regular case.
Yes.
Is there any indication when you would go?
Maybe so rare indications that some surgeons prefer to reach the intraforaminal herniations at the level of L5-S1. As you know, because the iliac crest is really high at the level of FS1, and it's not easy to reach the intraforaminal area because there is a high risk to damage the exiting nerve root there with the L5-S1 level. And then you can do a contralateral interlaminar approach to reach the contralateral intraforaminal area. But in this case, I would prefer again to extend a little bit bony resection to the facet joint in my side. Then I would prefer again the ipsilateral operation.
Dr. Yarikoglu, I have to say it again, it was a very impressive demonstration that you did today. As we don't have any more questions, see you next time. And if you liked what you saw today, give us a like in the video and subscribe to our channel. And see you next time. Stay safe. Bye-bye.
Okay, the next time is 3 hours later. I think we will do another approach, but this time I will do the approach at the level 3-4.
Stay safe.